Okay, dehydration. Now, before I enter into this topic, let me ask you, what is dehydration? Yes?
Loss of water from the body.
Deficiency of water.
Okay, so this is loss of water from the
Yes,
body.
loss of water.
Exactly, loss of water from the body. So you have to add one more terms along with water there, okay? Electrolyte is also lost. So if you use water and electrolyte loss from the body, that is a wonderful definition. Now let's move into the topic. See here. Before we go into the pathological aspect, let's talk about some physiological, aspect of this topic. What is the percentage of body weight composed of water according to the age group? See here, in premature babies or infant, 85% of the body weight is comprises of water. 85, that's a big percentage. Neonate, around 80. Around 3 months of the age, 75% of the body weight is composed of water. At 9 months, it drops to 70. And 12-year-old child or adult, we have approximately 60% of the body weight which is composed of water. 60%. Now, another important point, what is the normal circulating volume in our body? That means the blood. What is the volume of the blood in our body? So I clearly told you one important point in previous classes also. 8% of the body weight. Always remember that, okay? It is very easy for you after that. But that is the average thing in adult. In children, that's what we are talking now. We are talking pediatrics. In neonate, it is 90 ml per kg. In infant, 80 ml per kg. And in child, okay, older than that, it is 70 ml per kg. So if you calculate, according to the kg, this is 9% of the body weight. This is 8% of the body weight, and this is almost 7% of the body weight. We adults are having around 7 to 8% of our body weight. That is the blood volume in our body. So from now onwards, you should always answer like this, because whenever your teacher asks you, what is the blood volume in your body? If you are adult, fine, you can answer like that, right? But if a pediatric teacher asks this question, you cannot say 5 liter, 4 liter, 6 liter like that. That is too much blood for the pediatric age group. So try to answer like this. You can say 7 to 8% of the body weight is comprises of our blood. That is the perfect answer. Now with this, let's define what is dehydration and what is the importance of dehydration. Dehydration is a serious and potentially life-threatening condition in which the body contains an insufficient amount of water for normal functioning. Okay, so there is lack of water. This is a serious condition because we need fluid in our body. That fluid is divided into different compartments, intracellular and extracellular. These are the two big compartments in our body. Intracellular means inside the cells, extracellular outside the cell. Blood is a part of extracellular fluid. Now the term volume depletion is similar to dehydration. So we use this term synonymously with dehydration, but it refers to the loss of salt as well as water. Salt means electrolyte. So you can easily say the loss of electrolyte and water is equivalent to volume depletion, and volume depletion is the same word these days as dehydration. Now we are reaching to the important part. What are the types of dehydration? Let's classify dehydration. Now please pay attention here. It can be classified into different types. And that is in relation with sodium content, clinical, and according to World Health Organization. Okay, So different headings are there. So let's talk one after other. In relation to the sodium content, isonatremic, hyponatremic, and hypernatremic dehydration. Now, in the morning class, I asked to the students, what is the level of sodium in our blood? Okay, so let me ask that thing again. What is the amount of sodium in our blood? Once again,
135
135
to
to
145.
145.
exactly. Okay, absolutely correct. Sodium level in the blood is 135 to 145 milli equivalent, okay, per liter or millimole per liter. Now see here, isonatremic means the level of sodium is between this range. This is isonatremic, means normal. Hyponatremic, below this range, below 135, and hypernatremic is above 145. That is the meaning. So quite easy. Now one question must come in your mind. Now, what is that question? If we are losing water, then how sodium is excessive than 145? Usually that is the concept, isn't it? If we lose the water, we lose sodium as well along with the water. Then why I am using these three terms in the classification of dehydration? And the answer is very easy here. It is all about proportion of water and electrolyte loss. If both are lost equally, the dehydration is isonatremic. If we are losing more sodium than the water, the dehydration is hyponatremic. And if we are losing more water than the sodium, that means sodium is relatively more in the blood than the water now, so it will become hypernatremic dehydration. So you understand like this. Okay, so this is one of the classification. Another is a clinical one, which is very commonly used by the pediatricians when they work in the hospital. Mild dehydration, moderate dehydration, and severe dehydration according to the severity of dehydration. We'll talk about that. What are the important signs and symptoms in mild, moderate, and severe? And third is according to World Health Organization, that is very simply classified dehydration into no dehydration, when the signs and symptoms are not there, but there is a history of diarrhea and vomiting. Some dehydration means some of the clinical features, and severe dehydration are much more clinical features. Okay, so when we move on to the topic, everything will be crystal clear. Now, let's talk about what is the mortality and morbidity of dehydration, why this topic is so important, and what are the problems of this in our body. Now, first of all, you should know the meaning of these two terms, mortality and morbidity. Now, mortality is death and morbidity is illness. Okay, illness versus death. So dehydration can kill the child, and dehydration can also make the child sick. So that is the meaning. Morbidity varies with the degrees of volume depletion and the underlying cause. So if severe dehydration is there, morbidity is more. If mild to moderate dehydration is there, morbidity is less. If diarrhea and vomiting is causing dehydration, please mute yourself. Otherwise, I have to mute you. Okay. Now, if diarrhea and vomiting is causing a dehydration, the morbidity is something else. Okay. If burns is causing dehydration, the morbidity is something else. So it depends on the underlying cause as well. Another point, the severely volume depleted infant or child is at risk for death from cardiovascular collapse. Now, what do you mean by that? The severely dehydrated child is equivalent to hypovolemic shock. Hypovolemic shock, one of the important cause is severe dehydration. That is the meaning of cardiovascular collapse. Okay, now see there. Let me underline this important term for you. So the child can die because of this. Hyponatremia resulting from replacement of free water alone may cause seizure, and that can happen during the treatment. Let me give you one example quickly. If the parents are only giving water without any electrolyte to the child who is having severe diarrhea and vomiting, now there is no extra sodium given. They have given only water to the child. That child will suffer from hyponatremia, and that hyponatremia can lead to seizure. Okay, so this is one of the morbidity. Another one, okay, wait 1 minute. Okay, now if it is improperly managed, okay, if it is improperly managed, then it also leads to iatrogenic morbidity or mortality. Another good example I like to provide here: if the child is mild to moderately dehydrated, but we have given a lot of IV fluid to the child which was not necessary, there may be heart failure. The child may die from heart failure because of excessive fluid. This is clearly improper management. So these are the different morbidity and mortality associated with dehydration. Now we are moving to the clinical discussion here. What type of history you like to take if the child came to you or brought to you with dehydration? We want to know the cause, isn't it? So what history you take? See here. Ask about the feeding pattern and fluids given. Feeding pattern and fluids given. Usually dehydration is a part of malnutrition. The diarrhea and vomiting is a part of malnutrition. So what was the feeding given to the child during that time? Absolutely important question. And what type of fluid they give? Did they give only water, or did they give some electrolyte along with water? Very important question. And how much fluid they gave? Another one, how the fluid was lost from the body. Was there a history of diarrhea and vomiting or not? How much urine the child is still passing? If the child did not pass any urine in the last 24 hours, this is a very critical sign. This already shows kidneys are suffering because of hypovolemia. Now you already know the meaning of oliguria or anuria, isn't it? Oliguria means less amount of urine flow. Anuria means no urine flow at all. The urine is not formed by the kidney. So this is a feature of renal failure. Ask about the level of activity of the child. If the child was mildly dehydrated, the child becomes irritable. In moderate to severe dehydration, the child is lethargic or even in coma. So ask about the activity of the child. Very important question. Ask about the medication which was given to the child. These days, any of the parents know this thing. If their child develops diarrhea, what medicine they give? Yes, probably you also know that. So which medicine we give for the diarrhea? Anybody?
Metronidazole.
Pyramid.
Okay, metronidazole, loperamide. See there, different answers are quickly coming. Okay, now yes, please.
Loperamide.
Mm-hmm.
Loperamide, copoctate.
Mm-hmm. Okay, now let me tell you some very important practical points here. Okay, many of the diarrhea in children are caused by viruses. They are caused by viruses, so we don't need to give any medicine. That's the first thing. The only medicine the child needs is oral rehydration solution, ORS. that can be given at home or in the hospital. If the child is very severely dehydrated, we need to give IV fluids as well. But having said that, some of the diarrhea has to be treated by antibiotics also, like bacillary dysentery. Diarrhea is one of the part of that, okay? There is a difference between diarrhea and dysentery though, but diarrhea can occur, okay, because of the similar type of organism. So if you believe there is pus in the stool, there is blood in the stool, then probably antibiotic is necessary. Otherwise, if there is only watery diarrhea without any pus cells in the stool, without any blood in the stool, no antibiotics are needed. Remember this. Another one, heat and sunlight exposure. We need to take this history. If there is excessive exposure to heat and sunlight, probably the dehydration chance will be more. Now we have reached to the very important part of this lecture. What are the physical examination finding, okay, in a dehydrated child? We start with vital sign examination. Now see there are 5 vital signs these days, okay, and these 5 vital signs, I'm sure every student know that. I want to listen to this answer. Yes, please. What are the vital signs?
Pulse,
Blood
temperature,
pressure, pulse
blood
oximetry,
oximetry,
pulse,
the heart rate,
temperature,
Okay, temperature.
pulse
Very
oximetry,
good. Very good.
blood
Then
pressure,
blood
pulse
pressure,
oximetry,
good.
pulse oximetry,
Pulse
respiratory
rate.
rate.
and
res-
respiratory rate.
respiratory rate,
Very good. Pulse rate. Okay. Respiratory rate. Excellent. Then blood pressure.
Blood pressure,
And the last
pulse
one is
oximeter,
pulse
pulse
oximetry.
oximeter.
Excellent. Every student know this. 100% of the student know this answer. So you don't forget, because you are just starting your clinical phase. Okay. So that's why we need to repeat it again and again, so that it will stick in your mind. Now see here, what is happening in the case of dehydration. Fever hastens the fluid loss and resultant tachycardia and tachypnea. If the child is having fever along with diarrhea and vomiting or dehydration, there is more chance of fluid loss. Now fever will raise the temperature. That temperature will, okay, will not remain like that, isn't it? The child will have decreased temperature. And how the temperature is decreased? Because of the heat loss from the body, and that heat loss will also result in fluid loss from the body. This is called evaporation. So this is a very important point. At the same time, tachycardia and tachypnea occurs along with fever. They also leads to some of the fluid loss, especially tachypnea. Tachycardia is the resultant thing. It doesn't lead to fluid loss, but tachypnea or faster breathing can also lead to a bit of fluid loss, okay, through the respiratory passage. Though it is not a very important method, but nevertheless, it is mentioned like this in the textbook. One very important point for you, the pulse increases by 10 beats per degree centigrade of temperature rise above the reference range. Now see here. So this is a important practical point for us. The pulse rate or heart rate increases by 10 beats per minute, okay, per degree rise in temperature. If a patient has heart rate of 120, but fever is just, okay, fever is just 38 degrees centigrade, that rise in heart rate is not only caused by this fever, because it doesn't match. It doesn't match. It should not reach that 120 range with 38 degree only. So something else is there, and who knows, this is a case of dehydration. So that the explanation, okay, we should give. Tachycardia is an early sign of significant volume depletion. No doubt about it. It is an early sign. Even in hypovolemic shock, we learned about this. Blood pressure falls very late. Blood pressure falls very late. It is preserved until severe depletion is present. So don't rely on hypotension as a sign of dehydration. It develops very, very late, and tachypnea is usually present. Weight loss is important as a measure of the degree of volume depletion, which is very prominent in small babies. They lose significant weight as a result of dehydration. So if you take weight appropriately or accurately, you can know how much weight or dehydration has been there. So changes in activity level is also important. Drowsiness, poor interaction in the beginning, and later on the child develop coma. It depends on what is the level of dehydration. In the beginning, a bit irritability, then drowsiness, then coma. And if sodium is also altered along with water, there will be problem in the brain. Okay. One of the important point is seizure, and I'll explain to you later on what is the pathogenesis of seizure in case of hyponatremia. I'll take another class also about electrolyte imbalance, and we'll talk about it there. Okay, so we're talking about the physical findings in a case of dehydration. Now see here, all of you please pay attention on your screen. This is a very important slide which clearly tells us what are the important physical examination finding in dehydration in a child. Let's start from the head and go towards the toe. Now see there, okay, there is a sunken fontanelle. Now, can you tell me what is fontanelle first? What is fontanelle? Yes? Anyone? What is fontanelle? Who can tell me that? Can you hear me? Yes? Okay, so let me explain. I think all of you can hear me. Okay, so
It's an anatomical feature of the skull.
okay, fine,
The voice is
fine.
dropping.
Junaid, yes, yes, Uzair, you're saying something.
Sir, the voice is dropping, sir, constantly.
Voice is dropping. Really?
Yes, sir.
Can you hear me now?
Yeah.
Okay.
Yes, sir, now it is clear.
Okay,
Yes, sir.
fine. No, so let me explain this. Okay, we cannot ask all the students because it will kill a lot of time. So sunken fontanelle means the anterior fontanelle which is present in the baby who are younger than 18 months of age. Okay, the anterior fontanelle is closed at 18 months. So fontanelle is only present till that time, isn't it, or till that age. In case of severe dehydration, the anterior fontanelle is depressed. So this is called sunken fontanelle. And fontanelle is a gap between the suture, okay, between the different sutures like frontal suture and coronal suture, okay, a sagittal suture. So this anterior fontanelle is a big gap there. So we just put our finger, okay, or feel at that area by elevating the head of the baby. If it is depressed inside along with other features of dehydration, it is a sign of severe dehydration. Reduced level of consciousness is a feature of severe dehydration. There is dry mucous membrane in the oral cavity, and there is sunken eyes, as well as there is loss of the tear. Tear will be absent in case of severely dehydrated child, and eyes are sunken, means there is a sunken eyeball. We need to ask this finding to the mother. How long have you noticed the sunken eyes in your baby? And mother will definitely tell you, doctor, till yesterday the eyes were not like that, and for the last 24 hours my baby has developed this type of eye. This is a clear-cut evidence of severe dehydration. Tachypnea is a faster breathing or increased respiratory rate, very important feature. Reduce skin or tissue turgor. Okay, reduce tissue turgor means whenever we pull the skin of a healthy and normal child or even the adult, for example, the skin from anterior abdominal wall, that skin will go back very quickly. Okay, it will go back in no time. But in case of severe dehydration, the elasticity of the skin will suffer. As a result of this, it will take time to go back. This is known as reduced tissue turgor. Never forget this, one of the important feature of severe dehydration. Now another is oliguria. Oliguria is decreased urine output. All of us know that. Tachycardia, hypotension, and peripheral vasoconstriction are the features of hypovolemia. So many times we discussed this till now. Tachycardia is the earliest feature of hypovolemia. Hypotension is seen only in late and severe cases, and peripheral vasoconstriction is a feature of hypovolemia. Reduced capillary refill time, classical feature. Normally, the capillary refill time is less than 2 seconds, but in this type of severe dehydration, it is more than 2 seconds. Sometimes it may be 3 or even more than 5 seconds. So these are some of the very, very important points. So let me repeat again the important point. Let me choose from the list. Sunken fontanelle in less than 18-month-old baby only, not above that age. Reduced tissue turgor or skin turgor is very important feature in all age group. Reduced capillary refill time, it is a feature of severe dehydration. And sunken eyes, which can be seen very easily. Apart from them, ask the question about oliguria, okay, and then touch the baby. If there is peripheral vasoconstriction, that means if the peripheries are felt cold and a bit of clammy, this is also a feature of hypovolemia. Let's move on. Now, all of you, please pay attention on your screen here. What physical finding they are showing here? Just have a look. What physical finding is this?
It's a skin turgor, sir.
Exactly. This is skin turgor. This is reduced skin turgor, what they are showing here. Now just have a look here. This is a skin which is pinched up, or we lift up the skin. Usually it is done in the anterior abdominal wall. And then we look at the response. Okay, after leaving your finger, how quickly the skin will go back. You just observe it there. If it goes down very slowly, along with other features of dehydration, it is one of the confirmatory sign of severe dehydration. Now please observe, okay, observe on your screen. What finding can you see there in these babies? Okay, all of you please have a look first and then answer. See there, please. Now, what is happening to eyeball here? Can you see it?
Yes, sir. Sunken eyeball.
This is called sunken eyeball. Excellent. This is called sunken eyeball. Now see there. Look at the eyeball here. And this child is very drowsy. This child is very, very drowsy. I can see, look at her face and then tell. Okay. It's difficult to say what is the sex of this child. So can be a boy or girl. Okay. That is not concerning for us. But some of the features are very, very important here. One is sunken eye. Another is very lethargic or drowsy child. Now have a look here. That's the reduced skin turgor which I was talking just now. This baby is very small, probably an infant. Okay, so if we pinch the abdominal skin and leave our finger, if it goes back very slowly, this is a sign of severe dehydration. At the same time, this baby also has a bit of sunken eye. So these are the important physical findings. Now with this discussion, let's talk about what do we mean by mild volume depletion, moderate volume depletion, and severe volume depletion. Okay, what are the physical findings? They are present in each of these conditions. So mild volume depletion means, okay, when we are losing around 5% of the intravascular fluid, around 5%. So to be very precise, it is 3 to 5%. When that much of fluid is lost from the body, it is called mild volume depletion or mild dehydration. It is corresponding to approximately 50 ml per kg loss of body weight. 50 ml per kg loss of body weight. Remember, 5% means 50 ml per kg loss of the fluid. 10% means 100 ml per kg of the fluid loss. 15% means 150 ml, okay, per kg of the fluid loss. This is a very important point to remember. Many students will make a mistake. Later on, I will teach you how to calculate what is the percentage of fluid loss from the body, and we will talk according to the percentage here. 7% means 70 ml per kg of fluid loss. 8% means 80 ml, like that. The physical signs are minimal or absent in case of mild dehydration, and these are thirsty. The child is very thirsty. The child is asking for the drink, asking for the water, and if the child gets the water, the child will finish that glass of water or cup of water in no time. This is thirsty, one of the feature of mild dehydration. If you examine the pulse, it is slightly increased only. Urine output is still normal or slightly decreased, but we believe it is still normal. It is very difficult to find out slightly decreased or not. Mucous membranes are moist and tears are still present. There is normal skin turgor and there is normal capillary refill. So how to diagnose mild dehydration? Very difficult. So we just presume, if there is certain history like diarrhea and vomiting, we presume this child is having mild dehydration. Now, on the other hand, what are the features of moderate dehydration or moderate volume depletion? Now, please pay attention here. This corresponds to 100 ml per kg of fluid loss. To be very precise, it is ranging from 7 to 10% of the loss of body weight. In this condition, the tachycardia is present even at rest. During exercise, during walking, we all of us will develop faster heart rate. Okay, we are not talking about that now. Even at the rest, there is tachycardia in case of moderate volume depletion, but blood pressure is still normal. Capillary refill time is prolonged now. It is more than 2 seconds. Okay, it is more than 2 seconds. So let me write that here. It is important for you for later on. Okay, more than 2 seconds. Now many students are a bit confused about this capillary refill time, so let me explain this once again. Capillary refill time is mainly done, okay, on our nail bed. So we just press the nail bed, okay, for a few seconds and suddenly remove our finger, and we see in how many seconds it will become pink or red again, and that is usually less than 2 seconds in a healthy person. If the person is dehydrated or in shock or having decreased perfusion there, then the time taken for the refilling is more than 2 seconds. It depends how bad is the condition. In case of severe dehydration, it is even more than 3 seconds or even 4 or 5 seconds sometimes. So these all are very important points. Now, in case of newborn baby, okay, the capillary refill time can be checked at the chest also, at the anterior wall of the chest. If you palpate the peripheral pulse, okay, they are weak. Now you are learning cardiovascular, system in internal medicine. Now I want to ask you one question. Which are those peripheral pulses which are palpable in the examination of cardiovascular system? Yes? Which are the peripheral pulses?
Radial
Carotid, radial, dorsalis,
Posterior tibial artery,
Good.
posterior tibial artery,
femoral artery.
dorsalis pedis, femoral,
Dorsalis pedis and the posterior tibial artery, sir, and we've got the coronary arteries and the
temporal
radial.
artery.
Very good. So good answer. Many of the students know this. Excellent. So from the head and neck area, we have carotid artery. If you remember that name, you have done well. Carotid, and one more is superficial temporal. You can also palpate that. From the upper limb, we have brachial and radial. Okay, brachial and radial. From the lower limb, we have femoral, we have popliteal, dorsalis pedis, and posterior tibial. So these are called peripheral pulses. Having said that, in case of dehydration or hypovolemia, you feel for strong type of pulses like a carotid from the neck and femoral from the lower limb. So these are mainly palpated in this type of condition. The child is also having irritability and lethargy. Now, irritability is present in a bit of milder type of volume depletion, and lethargy is present in moderate to severe. So in the beginning, the child becomes irritable, then lethargy and excessively sleepy, and ultimately the child develops coma. So this is the way in case of volume depletion. There would be dry mucous membrane. Now, which mucous membrane we can examine very easily? Yes, which are those mucous membrane? You should understand this. Mucous membrane means you can examine conjunctiva of the eye and oral mucosa. So these are the meaning. So if you examine eye, there will be lack of the tear. The conjunctiva will become dry because no tears are flowing there. And if you open the mouth of that child, there is no saliva. So the oral cavity is also dry. Means the secretions are dried up now. It is a feature of moderate to severe volume depletion. There is depressed anterior fontanelle. We already talked about this. There is shrunken eyeball and there is dry skin. So these are the features of moderate volume depletion. Now, the last one is a severe volume depletion, the most severe among them all. So let's talk about it. It corresponds to more than 100 ml per kg loss of body weight, and approximately it is ranging from 10 to 15%, okay, of the loss of body weight, or that much percentage of the water is lost from the body. In this condition also there is resting tachycardia, but one of the findings which is not present in the moderate dehydration and it is present in the severe dehydration is hypotension. Hypotension is a decreased blood pressure. Okay, so it is present only in the very serious condition. There is greatly prolonged capillary fill time, probably more than 3 seconds, weak central pulse like carotid, and cold mottled skin, cold and mottled skin because of vasoconstriction everywhere. The child cannot drink properly because the child is very drowsy or even in coma. So we don't try to give oral fluid in this type of child. So what happens if they are already in coma, or if they are excessively drowsy, and if we give oral fluid, what is the danger?
So it will not be digested.
Exactly. They cannot swallow it, number one, and there is always a risk of aspiration. It will go towards the airway, it will reach the lung, and will convert that child into a pneumonic child now. So never do this. If the child cannot drink, if the child cannot respond, do not give anything orally. That is very hazardous. There is altered sensorium with poor response to painful stimuli, and the child can even be comatosed. Okay, so these are some of the important points in severe dehydration. Now in the exam, this is a common question your teacher would love to ask. What are the main differences between moderate dehydration and severe dehydration? So which point you got from this discussion? Yes, what's the answer? So
It's
what
the hypotension and the
yes, good. Hypotension, very good. Anything else? He is absolutely correct. Okay, he is absolutely correct. The only point which is very, very clear that was not mentioned in moderate volume depletion is hypotension here. All other features are a bit more than the moderate volume depletion, but those features are present there as well. So please take this, okay, as a take home messages from this class. If blood pressure is low, then this is already a feature of severe dehydration. Now let's talk about the diagnosis of dehydration. Now see there, you have talked almost everything, so let's arrange them nicely. So when you examine the child, how you confirm the diagnosis of dehydration? So we ask something, we look for something, and we feel for something. We collect the data and then ultimately reach to the diagnosis. So what are the things we ask? Ask about the history of diarrhea and vomiting. Ask about whether the child is thirsty or not, and ask about the urine output. These are the very, very important questions. You should never forget. Diarrhea and vomiting is asked to know about the cause of dehydration, and that is the most common cause. Thirst. In case of mild dehydration, and even in the earlier cases of moderate, the child is thirsty. And urine output, we always ask to know how kidneys are functioning. Okay, if kidneys have already suffered because of decreased perfusion, what happens to the urine output? It will be low. That is called oliguria. Oliguria. Second one, look or run your eyes on the body of the child. Look for the general appearance. Is the child irritable? Is the child lethargic? Or is the child in coma? These are the 3 points. Is the child irritable? Is the child lethargic? Or is the child in coma? Now, irritability is a feature of mild dehydration, lethargy, moderate, and coma in very severe dehydration. Look the eyes of the child, whether they are sunken or not. Sunken eyes are a feature of moderate to severe dehydration, and lack of tear in the eye is also a feature of moderate and severe dehydration. Examine the oral cavity and look whether it is moist or not. In case of moderate to severe dehydration, there is lack of saliva. The saliva is not produced at all, so the oral cavity is dry. And look for the breathing. Now what happens to the breathing in case of dehydration? Yes, what happens to the breathing?
Sir, tachycardia. Tachypnea, sir, tachypnea.
Tachypnea, very good. Exactly, it is increase. It is called tachypnea. Very good. It is called tachypnea. Excellent. Now let's go to the third type of things here, that is feeling. Feel for the skin. Examine for skin turgor. Examine for skin elasticity. In case of moderate to severe dehydration, the skin turgor is reduced. It takes time for that pulled skin to go back. Very important point. Feel for the pulse. There are two things I'll feel for the pulse. One is rate, another is volume in this case, okay? There are so many other things we can examine in the pulse. Forget about that now. In this hypovolemic condition, only two things are important, rate and volume. So rate is increase and volume is decrease. This is called weak and thready pulse. So let me write that term for you, weak and thready pulse. Okay, so this is hypovolemic condition. And examine for fontanelle in case of infant, especially up to the age of 18 months, we can examine anterior fontanelle. After that, anterior fontanelle is closed. So do not even mention the anterior fontanelle after 18 months of age. Okay, so let's move further. Now, what are the causes of dehydration? Or in the other word, what are the causes of diarrhea and vomiting? So all of the students, please pay attention here. These are the common causes of vomiting. We have grouped them into different causes according to the pathology, like central nervous system causes, like CNS infection. Can you name some of the CNS infection? Which are those infections that occurs inside our brain? Yes?
Meningitis.
Meningitis,
And
good. Encephalitis, encephalitis,
this
exactly.
pyogenic meningitis.
Okay, there are different types of meningitis, okay, like pyogenic, viral, tubercular, isn't it? Different types are there. Then encephalitis, brain abscess, and cerebral malaria. Whenever this question is asked, you can quickly take these four names. Okay, these are the four examples. So let me repeat again: meningitis, encephalitis, brain abscess, and cerebral malaria. These are called CNS infection. All of them can lead to vomiting because of raised intracranial pressure. Because of raised ICP, the vomiting is very common. Another common cause is space occupying lesion inside the brain, like brain tumor. Okay, brain tumor, which is very common in children. Again, brain abscess. Abscess is considered as a space occupying lesion because it is a mass. Hematoma, which occurs because of blood clot inside the brain. Neurocysticercosis. If a tapeworm reaches the central nervous system, it is known as neurocysticercosis, the tinea swollen type of tapeworm. So all of these are example of space occupying lesion, which can also lead to raised intracranial pressure and then vomiting. These vomitings have a very characteristic feature. This is called projectile vomiting. Okay? Projectile vomiting. These are very catchy point. Okay, you will study this later on, I know that, but still, whenever the time is appropriate, okay, so let me write this thing for you. Projectile vomiting. Now, other causes are gastrointestinal causes, like gastroenteritis. Gastroenteritis means another term of diarrhea. GI obstruction, like intestinal obstruction, like pyloric stenosis, duodenal atresia. Any example you can take here. Hepatitis, viral hepatitis is a very important cause of vomiting. Volvulus, we have studied this in pathology. This is a twisting of the bowel, which also leads to intestinal obstruction. And pyloric stenosis, I have already taken this name. So these are some of the causes from GI tract, but two important ones from the medical point of view are gastroenteritis and hepatitis. The endocrine causes like diabetic ketoacidosis and congenital adrenal hyperplasia can also lead to vomiting. And if excessive vomiting is there, it can easily lead to dehydration. Now, okay, these are the special topic which we will deal later on. Diabetic ketoacidosis is a feature of type 1 diabetes where there is no insulin at all. And congenital adrenal hyperplasia, the name itself suggests it's a congenital condition where adrenal gland is hyperplastic. It doesn't synthesize any cortisol or aldosterone. On the other hand, it will synthesize more androgen. This is a feature of CAH or congenital adrenal hyperplasia. From the renal, UTI, pyelonephritis. Now, what is pyelonephritis? Yes?
Infection of urinary tract.
Okay, good. This is inflammation and infection of renal parenchyma. This is how you have to answer. This is a very safe answer. Renal parenchyma. See this. Nobody will ask what is renal parenchyma because this question is not asked to the medical students, okay, or clinical student, I should say. This we presume you already know this. Parenchyma is a cellular component of any organ. It is a main functional unit of the organ. So if that is infected in kidney, we call it pyelonephritis. Now another important cause of dehydration is diarrhea. So let's talk about what are the causes of diarrhea now. Again, GI or gastrointestinal like gastroenteritis, malabsorption, and short gut syndrome. These are the common causes. Celiac disease is a common cause of malabsorption. Celiac disease, which is a type of autoimmune disease. Now, short gut syndrome, it's a very interesting condition which is developed by resection of the intestine. And resection of the intestine may be necessary in the treatment of ischemic colitis, okay, or ischemic mesenteric disease. So that part of the intestine is already dead. So we need to remove it. We need to resect it. After that, the total length of the intestine is very short, and that intestine cannot absorb the food, which leads to malabsorption and then diarrhea. This is the meaning of short gut syndrome. Endocrine causes which are leading to diarrhea are thyrotoxicosis and congenital adrenal hyperplasia again. Thyrotoxicosis is excessive release of thyroid hormone, also known as hyperthyroidism. Because of excessive GI motility, there will be diarrhea. Pyelonephritis also causes diarrhea. Different type of infection in the body of a child can result in diarrhea as well as vomiting, like pneumonia, otitis media, sinusitis, and sepsis. These are the different examples of infection. Like, what is otitis media?
Inflammation of the middle
ear.
Inflammation of middle ear. Excellent. Inflammation of middle ear is called otitis media. Media is middle ear, okay? Otitis is the inflammation of the ear. Sinusitis is inflammation of paranasal sinuses like frontal sinus, maxillary sinus, ethmoid sinus, and sphenoid sinus. Having said that, maxillary and frontal are the most commonly affected. And let's not forget about anxiety as a cause of diarrhea, and this belongs to a psychiatric group of disorders. Sometimes we do extensive investigation, but no cause can be identified. This may be a manifestation of anxiety, like irritable bowel syndrome. There is a condition known as irritable bowel syndrome, which we will talk in medicine later on. In that condition, usually the patient is complaining of abdominal pain and diarrhea. Okay, now probably this will be the last slide for today, and I'll repeat some of the important points definitely in my next class also. What are the investigation you like to do if a child comes to you with diarrhea and vomiting, or dehydration. Now just go through this. Serum electrolyte. Now let me ask you a question. Why serum electrolytes are important in investigation here? Why?
Sir, mainly because serum electrolytes mainly control the GIT mortality, which also related with the diarrhea,
Okay,
like potassium.
good, good. Any other?
Because many mineral loss influences it.
Okay,
Like, say, for example, the sodium said directly to sir water. So, like if sodium is lost, so you got direct dehydration, sir. Like directly the fluid is lost. So that's why serum electrolytes are quite important.
okay,
And sir, like glucose, which also osmotic diuresis and also cause dehydration.
okay.
Like
Now,
sodium is
okay,
extremely important for process of osmosis.
fine. So, different answers are coming. Okay, very good. It's quite encouraging. Please continue to answer. Okay, do not hesitate. Do not have that awkward feeling when I ask the question. Even if you know a little bit, you can confidently answer. I'll never criticize my students. Even if you are wrong, I'll not pull your leg here. I'll always promote you to answer, because it will have that feeling of confidence in you. Now listen here. Serum electrolytes importance are sodium and potassium in this regard. If there is a severe type of diarrhea and vomiting along with fluid loss, the child will lose sodium and potassium as well. So if we do not examine them, or if we do not know their level, then how I know what is the amount of sodium and potassium in the body? So in any case of diarrhea and vomiting, if it is severe one and if it is a chronic one, never forget to order sodium and potassium level. To classify which type of dehydration, we need sodium. Now remember, there are three types of classification according to sodium level: isonatremic, hyponatremic, and hypernatremic dehydration. So this type of answers you can give very confidently. Now blood urea nitrogen and serum creatinine, these are called renal function test. Renal function test. We must know what is the status of kidney in severe dehydration. If these are high, we already know kidneys are suffering. Glucose. Remember, diabetic ketoacidosis is one of the cause of diarrhea and vomiting, both. So glucose level will be very high in case of diabetic ketoacidosis. Serum osmolality, similarly it is high in case of dehydration when there is excessive fluid loss, or in case of diabetes again. Osmolality means how heavy is the serum. Arterial blood gas or ABG analysis is done in severe volume depletion or dehydration. This is a state of shock. This is a state or condition of hypovolemic shock, and usually in case of shock there is metabolic acidosis. We can diagnose that with the help of ABG. And urine analysis, in case of pyelonephritis, there is a chance of diarrhea and vomiting, so it will confirm by urine analysis. Regarding the management of dehydration, we have to know the concept of maintenance fluid, replacement, or deficit therapy. Now let's talk about what is maintenance fluid. Now these are the goals of maintenance fluid, so you'll understand by yourself when I go through this. We need to have fluid every day. Why we take fluid? Number one, to prevent dehydration, definitely. Number two, to prevent the electrolyte disorders. We do not take only water. We will have some salt there. For example, we take different types of food, isn't it? Some electrolytes are already there. If we eat fruit, the electrolytes would be there. So this is important point. To prevent ketoacidosis, maintenance fluid has to be taken. And what is ketoacidosis? Anybody? What is ketoacidosis? Yes.
So there is a
Sir, in acidosis, there are ketone bodies. So the ketone body are formed, so that
ketone
ketone
bodies.
bodies are deposited in the body. So this is known as ketoacidosis, sir.
Okay. Now, Irfan, yeah, you are answering. So, can you tell me what are the types of ketone bodies? Yes. Anybody else?
Sir, there are three types of ketone bodies. Sir, the acetoacetate, the beta hydroxybutyrate, and sir, the acetone is the third one.
Okay, good, very good. So, sometimes the student cannot hear me because of the network problem. I can clearly understand that. Okay, so listen here. That's why I'm recording all these things and provide you later, so that even if you cannot hear right now or cannot listen to the explanation, please follow it later. Everything will be there. Now, there are three important types of ketone body: beta hydroxybutyrate, acetoacetate, and acetone. Acetone is a gas. Okay, acetoacetate and beta hydroxybutyrate are the substances which are present first in the blood, and acetoacetate later on is excreted in the urine. So these are the ketone body. If we take slight amount of glucose along with the fluid, formation of ketone body will be prevented. We need to have slight amount of glucose with our maintenance fluid to prevent ketoacidosis. Now, another goal of maintenance fluid which we take every day is to prevent protein degradation. So these are the goals of maintenance fluid, and we have to take it every day. Now, another important point here is we have to take enough amount of electrolyte to maintain the serum electrolyte at normal level, and this is the requirement of sodium and potassium in 24 hours or in a day. So sodium is 2 to 3 milliequivalent per kg per 24 hours, and potassium half of that, 1 to 2 milliequivalent per kg in 24 hours. So these are the requirements. And if we take balanced diet, we don't need to worry about the intake of sodium and potassium. They are already there. Balanced diet is the concept which is important here. Now, I want every student to pay attention here. This is the way by which we calculate maintenance fluid, and that is according to the body weight. So it is known as body weight method for calculating maintenance fluid volume. So if the child is up to 10 kg, we give 100 ml per kg of the fluid. Remember, this is the maintenance fluid. Now see here. Okay, from 0 to 10 kg, we give 100 ml per kg of the fluid. From 11 to 20 kg, we add 50 ml per kg extra. Okay, now what does that mean? See here, first 10 kg, you have already given 1000 ml. And how I get that 1000 ml? Because of 100 ml for 10 kg child. So 100 times 100 is 1000. So it is quite clear. And after that, till 20 kg, I will give 50 ml per kg for each of the kg. Okay, I will calculate some of the problem. Okay, and then it will be very clear for you. Now, for more than 20 kg, see here, we give 1500 ml because till 20 kg you have already given 1500 ml. So we need to calculate that also. And after that, you just add 20 ml per kg for each kg. So let me take an example and explain to you. Now, let's say the child which we are looking or examining is 22 kg. Okay, 22 kg is the weight of the child. Now the question is, how much maintenance fluid this 22 kg child needs? Okay, so let's calculate it now. So all of you, please, you can also try from your side. So how much maintenance fluid the child needs? Now see there, for 20 kg, the child already needs 1500 ml. Okay, for 20 kg, the child already needs 1500 ml. Now how I got this 1500 ml? It's very easy. For the first 10 kg, the child gets 1000 ml, and for another 10 kg, the child just needs 500 ml. So 1000 plus 500 is 1500. Clear? Now after that, what I am going to do here now, just 2 more kg is left, and for that I need 20 ml per kg extra. So 20 multiplied by 2. 20 multiplied by 2. So how much it would be now? You can calculate. Yes. What is the total amount of fluid now? What is the how much it comes? Yes. 1500 ml plus 20 multiplied by 2. So it is 1540 ml.
14, sir.
Exactly. So are you clear regarding this maintenance fluid calculation? Yes.
Yes, sir.
If somebody is not clear, let me repeat again by giving another example for you. See there. Now this time I am taking the example of 18 kg child. Now if the weight is 18 kg, all of you please calculate what is the maintenance fluid requirement for this child. Yes, go on. If you are wrong, then I'll correct it. Okay, do it please. I'll give you 30 seconds for this.
So it will be, sir, 1400 ml, sir.
Okay, so you got 1400 ml. Anybody else?
1400 ml.
Good. So Adnan also got 1400 ml. Anybody who has not understood? Okay, this is very important one in this in today's class. Okay, I will mainly focus on this type of problem. Now see here how they reach to the 1400 ml. So for that, for the first 10 kg, already 1000 ml fluid, okay, is required. Now only 8 kg is left behind, and till 20 kg I will give 50 ml, okay, per kg. That means I need to multiply this 50 by 8. So definitely it will be 1400 ml. Very good, 1400 ml. So this is the way we calculate what is the maintenance fluid requirement up to 30 kg, and after that it's almost like an adult. Let's move on. Now if the child is severely dehydrated, we need to give IV fluid. You all know that. Okay, in today's class I'll talk in detail about that. But how much IV fluid I will give now, and how to give, what is the process of giving this fluid? As an MBBS student, as a young doctor, we must know how to manage dehydration, because so many of our children or even the adult, they are dying because of dehydration as a result of severe diarrhea and vomiting. And this is very easy management if you know. Okay, so please pay attention properly. The first thing is restore intravascular volume, and that is done by giving crystalloid like normal saline or lactated ringer at 20 ml per kg bolus over 20 minutes. This is called bolus. We give it very fast over 20 minutes. Okay, so this is the first thing. And how many boluses we can give? Up to 3. Maximum boluses we give up to 3. So sometimes even 2 boluses are enough. But if the blood pressure is not rising, if the pulse rate is not decreasing, then I can give up to 3 boluses. Now let's quickly take one example here. If the child is again 20 kg, in each bolus, how much fluid should I give now? 400 ml, because 20 ml per kg means if it is a 20 kg child, I multiply 20 by 20, it will become 400 ml. So in each bolus, 400 ml fluid is given over 20 minutes. If I am not satisfied, I will give another 400 ml, and third bolus of 400 ml can also be given. So 3 boluses of 400 ml is 1200 ml. This much fluid can be safely given in case of severe dehydration during the management. Let's move on. Another is calculate 24 hours water need now, and that is done by maintenance water or maintenance fluid requirement, which we have already spoken, and deficit water because of the percentage of dehydration, how much water the child has lost from the body. Now, in the first class of dehydration, I clearly told you 5% dehydration means 50 ml per kg fluid loss. 10% dehydration means 100 ml per kg fluid loss, and 15% dehydration means 150 ml per kg fluid loss. Never forget it. This is known as deficit water. We need to add both these, maintenance and deficit water, and that much fluid is given in 24 hours. So see here, administer half the calculated amount during first 8 hours, and we need to subtract the bolus, whatever we have given before. You have given boluses like that, 20 ml per kg. If you have given 3 boluses, you need to subtract that amount from the first 8 hour fluid, and remaining fluid will be given over 16 hours. So I will take a different example and explain to you, okay? Don't worry. But this is the principle you need to understand first. At the same time, you should calculate the 24-hour electrolyte need, like sodium 2 to 3 milliequivalent per liter, okay, per kg, and potassium 1 to 2. So give accordingly. And if the child is constantly losing fluid because of diarrheal stool or because of vomiting, replace the ongoing loss as well. Each of the diarrhea or vomiting episode, we can give extra 50 to 100 ml of the fluid. So this is how management of dehydration is done in the hospital. Okay. Now, all of you, please focus. I deliberately keep this slide as a blank slide so that I can explain how to calculate the things here. Okay. Now see here, please. Okay. Now let's take an example, a 25 kg child. This is the weight of the child who has come to us with severe dehydration. Now, how do you, manage this child? Okay, that's the question. Now, what should we do? First, we need to calculate what is the maintenance fluid. Okay, maintenance fluid. Now, let's say this percentage of the dehydration in this severe dehydration. Okay, the child is having severe dehydration, and the percentage of dehydration is 10%. Okay, 10%. This is the problem which is given to you. Now calculate the maintenance fluid first. So how to calculate maintenance fluid in a 25 kg child? How much is the maintenance fluid the child needs? Yes, can you please tell me?
1600 ml.
1600 ml, sir.
1600 ml. Okay, good. So let me follow the process now, okay, so that all the students would understand it. 25 kg. So up to 20 kg, I need 1500 ml already. Everybody know that. Now only 5 kg is extra, and after 20 kg, I give 20 ml per each kg. See that? So it would be 1600 ml. Excellent. 1600 ml. Very good. So this is the maintenance fluid. Now another, task for us is calculation of the deficit fluid, means how much fluid the child has lost from the body because of this diarrhea and vomiting. So the percentage of dehydration given is 10%. Now just now I told you 10% means 100 ml per kg fluid loss. So what is the total weight of that child? 25. Okay, 25 kg. Let's not write kg now. We will calculate in ml or liter. So 25 kg, okay, multiplied by 10%. 10% means 100 ml per kg. Okay, 100 ml per kg. So how much fluid it would be? See here, 2500 ml. So the child has lost 2500 ml fluid already. Almost 2.5 liter of the fluid the child has lost. So let me repeat again how that 100 comes there. Every student should understand this, because the deficit is calculated as a percentage of dehydration, and 10% means 100 ml per kg fluid loss. His weight is 25 kg, so he has already lost 2500 ml of the fluid. Now, what is the total amount of fluid loss? Total fluid loss. Okay, what is the total fluid loss now? Add maintenance, I mean total fluid requirement I should say, okay, because maintenance fluid is not lost. Total fluid requirement in 24 hour, okay, is, you add these both together, 1600 ml, which is a maintenance fluid, okay, plus 2500 ml, which is a deficit fluid. How much it would be? 4100 ml.
4100 ml.
Is it clear till here? Is it
Yes,
clear
sir.
to everyone? Yes.
Yes, sir.
Now, how we give this fluid? There are different ways. If you want to give bolus, okay, let's say we give two boluses. Okay, we give 2 bolus in this child. So how to calculate the bolus? 20 ml per kg. The child is 25 kg weight, so it is should be multiplied by 20. So this is the bolus. Okay, so it would be 500 ml. So 500 ml is the bolus. I have given 2 boluses, so 500 multiplied by 2 equivalent to 1000 ml of the fluid. You have already given this as the bolus. Now, how much fluid is left and how we give that amount of fluid, okay? So let me explain that for you. We calculate the total amount of fluid. See that the total amount is 4100 ml. We divide this into 2 half. 4100 divided by 2, okay? How much it would be? 2050, isn't it? 2050. So first 8 hour I will give 2050 ml, and okay, remaining 16 hour I will give another 2050 ml, exactly half of the total fluid requirement. Is it clear? I think till it very clear, right? Now,
Yes, sir.
we have already given this bolus. See this bolus has to be, isn't it, adjusted now. You have already given, and this bolus fluid you have given from the 8-hour fluid requirement. So you have to subtract this 1000 ml from this 2050. So let's do that. 1000 ml. So the remaining fluid, probably 1050. So this 1050 ml fluid which is left behind in the first 8 hour should be given in that 8-hour time, and this 2050 ml fluid is given in remaining 16-hour time. This is how you manage dehydration in the hospital. And don't forget, if the child is constantly having diarrhea and vomiting, you replace that fluid as 50 to 100 ml extra, add it there, and then adjust the electrolyte concentration on this fluid accordingly by your lab investigation and things like that. So this is the way we calculate the percentages of dehydration. Okay, so let me delete it first. Fine. Now let's move further. So I'm sure every student are quite familiar to this. Now, how to monitor the child who is getting treatment with dehydration? How to monitor? The first thing and the most important one is vital signs measurement. Every 2 to 4 hourly, you have to monitor the vital sign. What is the pulse rate and what is the blood pressure? Now let me ask this question again to you. What happens to the pulse and blood pressure in severe dehydration?
Decrease.
Decrease, sir. Decrease.
Pulse rate is always increase, okay? It is not decrease, but blood pressure is decreasing in severe dehydration. Pulse tachycardia happens, but the volume of the pulse decreases. So you need to be very specific there. Don't say rate decreases. Rate always increase in dehydration, but volume of the pulse decreases. Whereas blood pressure is still normal in moderate dehydration, only it falls in severe dehydration. So what happens when we give the fluid now? The pulse rate should fall down because we are treating the child, and the volume of the pulse should increase. Whereas blood pressure should gradually go towards the normal range. So this is what we want. This is called monitoring. If we are not satisfied, we have to repeat the bolus. At the same time, monitor intake and output chart. This is done for fluid balance, means how much fluid the child has taken and what is the urine output in that child. At the same time, you can measure the specific gravity of the urine. The specific gravity means how heavy is the urine. Remember, in case of dehydration, the specific gravity is high than the normal. Physically examine the child for the weight. Okay, weight. The child should gain a bit of weight after giving fluid therapy, and whatever signs of dehydration was there before, they should disappear. They should disappear. The sunken eye should disappear. The child should have moist oral cavity and tears should come now. Urine should be passed normally and all those things are there. But one important point, don't overload the child. Do not give a lot of fluids so that the child will develop pulmonary edema. You need to be careful. Now, what are the signs of pulmonary edema? Who can answer that? What are the signs of pulmonary edema?
Bilateral basal
Peacefully.
Good. One is bilateral basal crepitation. Very good. Excellent. That is the most important physical finding. I completely agree with you. Now listen properly here. You are treating a child with dehydration. You have given too much fluid. So the danger here, that fluid may have collected inside the lung, inside the alveoli. So keep on auscultating the base of both lung. If you hear bilateral basal crackle, it is always almost confirmatory that you have given a lot of fluid. So during that situation, how to handle? What should we do now? Yes?
use of diuretics.
Exactly.
Diuretics.
Exactly. Exactly. Okay. Do not give the fluid because the child has already got a lot of fluid. Stop giving fluid, number one. And number two, give one shot of furosemide, which is a loop diuretic, the most potent one. And all those excessively collected fluid in the body would be flushed out. Excellent. Okay. And then send blood for serum electrolyte also. What is the level of sodium and potassium? We need to know about that. This is how monitoring is done. Now, after doing this, let's talk about oral rehydration therapy. Oral rehydration therapy, also known as oral rehydration solution, it's the same thing. Now, this is available everywhere, all over the world, wherever, whichever medical shop you go, oral rehydration solution is available. Now, how to give to the dehydrated child? In case of mild dehydration, see here. In case of mild dehydration, the ORS is given like a 50 ml per kg within 4 hours. So this is a rough estimate of how much ORS we should give to the child. In mild dehydration, 50 ml per kg ORS within 4 hours. But in moderate dehydration, you have to increase the amount of ORS, and that is 75 to 100 ml per kg over 4 hours. So this is a lot of ORS, and it is very difficult for that child to convince to take this ORS. Many of the child, they don't like to take ORS, but it's the job of the parents, it's the job of the nurses or the sister. Okay, they should constantly try to feed the child with ORS. This is the treatment here. This is such an important point. If the child is not drinking at all, okay, then we have other options like NG tube. Put an NG tube inside the stomach and then put ORS through the NG tube. That is one option. And another is IV fluid. Put IV cannula and then give the fluid. Supplementary ORS is given to replace the ongoing loss. See this, ongoing loss from diarrhea or emesis. Emesis means vomiting. So we need to give supplementary ORS, a little bit more than this amount. An additional 10 ml per kg is given for each stool. Breastfeeding or other usual feeding should be continued or allowed after rehydration. You don't need to stop them. If the child is breastfeeding, just continue that. So this is called oral rehydration therapy. Now a little bit of practical information, because many students don't know that. How to prepare ORS, isn't it? It is available in a packet form. It is just a one packet. So how to prepare that? We should, okay, use 1 liter of water. Now listen here, 1 liter of water. And what type of water? The water should be boiled first, and that boiled water should be cooled down. Don't put ORS in a hot water. First boil water, because the purpose of boiling is to kill all the microorganisms whatever are there. Okay, that is the purpose. Cool down the water, and then we have to add 1 packet of ORS. 1 packet of ORS. See there. Now some of the parents may argue, my child is very little, so why don't I add half packet of ORS in half liter of water, or maybe 400 ml of water or something like that. That is a rubbish question. Okay, you should dismiss that question. Actually, it is not never prepared like this. 1 packet of ORS has to be added and 1 liter of water, and then give to the child. Whatever the child can consume, it's nice. And after a few hours, after the child discards it, discard that ORS also, discard that water which we have prepared. For the next time, prepare it freshly. This is very, very important. This ORS is not a expensive medicine, and in all over the world actually, okay, the government is providing it for free. So we need to convince the parent about proper preparation of ORS and how to consume it. Let's move on. Now, one of the very important slide, a lot of questions you can get from this in your exam. How to compare, or what is the comparison between standard ORS and new ORS? Now, standard ORS is the ORS which was developed by WHO, or it is was used mainly in the adult, especially in cholera patient. It was used, and it was developed to use in cholera patient as well. But it is still very commonly used all over the world, especially in adult. But in children, especially if they develop diarrhea and vomiting and dehydration, we don't like to use standard ORS. We like to use new ORS. So it is a little bit modified version of the standard ORS. So what is that modification? What is the difference between them? So let's go through that. Look here, look at the composition. Sodium chloride is there in ORS, glucose is there, potassium chloride is there, and trisodium citrate dihydrate is there. Okay, so you can simply call it citrate. So sodium chloride, glucose, potassium, and citrate. And in standard ORS, this is the gram. This is the amount which is present. 3.5 gram. Glucose is 20 gram. Potassium chloride 1.5 gram, and citrate is 2.9 gram. In new ORS, it is decreased. Sodium chloride drops to 2.6, glucose 13.5, potassium chloride 1.5, it is same, and citrate is also same. Now rather than this gram, okay, we love to ask in this way, millimole per liter. So what is the amount of sodium in standard ORS and in new ORS? See there, standard ORS 90, new ORS drops to 75. Chloride 80 before, now it's 65. Glucose was 111 in standard ORS, dropped to 75 in the new one. Potassium is same and citrate is same. Now this is called osmolality. The total osmolality of standard ORS is 311 millimole per liter. Okay, milliosmol per liter we should say, and in new ORS it's 245. Now one question must be arising in your mind: why? Okay, the World Health Organization has revised this ORS. Who can answer this to me? Why have they done it? Any idea? Now listen here, listen to the answer. They have revised it because the amount of sodium and chloride and glucose was way too high for that child, and easily the child can get hypernatremia. Hypernatremia after giving the standard ORS. That's why the concentration of sodium is decreased, and to decrease the osmolality of the overall fluid, the glucose concentration is also decreased. So that's the answer. So 245 is the new osmolality. Earlier it was 311. Now another question: what is the role of glucose here? Why glucose is used as one of the constituent of ORS? Remember, whenever glucose diffuses into the cells, it always carries sodium along with it, and from the intestine, when that ORS is getting absorbed, glucose will draw sodium along with it. So that's why glucose is always mixed in the ORS. Now let's move further. Let's talk about World Health Organization guidelines for the management of dehydration now. The guidelines provided by WHO are slightly different, okay, from what we use in the hospital. And that question must come in your mind: why WHO is providing these guidelines which are separate or which are different from the management which we regularly use in the hospital? And the reason behind it is, sometimes what happens, there are lots of dehydration cases because of epidemicity of diarrhea and vomiting, because of gastroenteritis. So during that time, the hospitals may not have enough bed, okay, to admit the patient for 24 hours and manage accordingly. So according to WHO, the dehydration can be managed maximum in 6 hours in case of infant, and in older child or children in 3 hours. Just in 3 hours and 6 hours, the dehydration can be managed if we follow WHO guideline. You don't need to admit the patient for a longer time in the hospital. So for that purpose, this type of guidelines are devised. Now let's see here. In case of no dehydration, you don't need to admit the patient in hospital. It is treated at home with home prepared fluid, and you can give ORS as well. Some dehydration is treated by giving ORS, oral rehydration solution, and I already told you how to prepare it. In severe dehydration, we have to give IV fluid. We need to give IV fluid. Now, IV fluid is given with the help of IV cannulation, but sometimes IV cannulation would be very challenging, or as a result of hypovolemic shock, the veins are already collapsed. So during that time, we have to give fluid anyhow, isn't it? So another way is intraosseous needle. So let me say a little bit about this. Intraosseous. What do you mean by intraosseous? Yes, what is that? Into the bone. Intraosseous means into the bone. Now there are different parts of the bone, isn't it? The outermost covering is called periosteum. After that is the cortex, and innermost part is called medullary cavity. It's a hollow cavity. So when we put a very strong needle into the bone and the tip of that needle reaches the intramedullary or medullary cavity, we can easily give fluid through that route. Remember, this is the emergency procedure, because if possible we always want to give IV. If IV is not possible because of lack of expertise or because of failure of the cannulation, then only intraosseous needles are used. Now, see here.
Excuse me, sir.
Yes.
Sir, please. Can you tell me about how it in intraosseous method how fluid delivered to body?
Okay. So let me. Okay, I got your question. Okay, let me explain this further. This intraosseous needle is already available in the hospital. You just need to order the sisters. They will bring you the tray. Okay. If those special type of needles are not available, then you can also use bone marrow needle for intraosseous fluid replacement. And the common site in case of small babies are anterior surface of the tibia. So let me explain it further. Anterior surface of the tibia. Okay, just below tibial tuberosity. Tibial tuberosity. Now this is a type of, isn't it, bony landmark on the upper part of the anterior surface of tibia. So we just palpate that tibial tuberosity, and around 1 to 2 finger breadth below we clean that area nicely. Okay, and if you have already intraosseous needle, then you drill that needle into the bone. You need a little bit of force or power there, and when it reaches the medullary cavity, you attach the another end of that needle with the line, the IV line, and give the fluid. If the fluid doesn't go nicely, you can even push the fluid directly by the syringe. This is how we manage a severe dehydration. But let me repeat again, this is only in emergency situation. If you fail to get IV line, IV lines are always preferred over intraosseous. Now, how much fluid should be given according to these WHO guidelines? How much fluid? Now let's talk about that. So all of you please focus here, and that is 100 ml per kg IV normal saline or lactated ringer should be given as follows. If the age is less than 12 months or infant, in 1 hour we give 30 ml per kg, and in rest another 5 hours we give 70 ml per kg. In older children more than 1 year, see there, 30 ml per kg is given in the first half an hour and 70 ml per kg is given in 2.5 hours. So the time is considerably decreased because of WHO guidelines. Let me repeat again, it depends on you. If you have enough bed in your hospital, if you have enough manpower, if the patient party wants to get admitted for at least 24 hours, even more than that, you can safely go with the option which I discussed little while earlier. If you do not have, okay, a lot of cases are there and not enough manpower, we safely go with this option. Now, what are the complications of dehydration? Now see there, these are the common complications. Hypovolemic shock, no need of any discussion. Severe dehydration is equivalent to hypovolemic shock, and that loss of fluid is most commonly because of diarrhea and vomiting in children, also known as gastroenteritis. Seizures can occur as a complication of dehydration. Now there are multiple reasons for the seizure. Let me explain some of them. Seizures may occur because of hypovolemia, and as a result of this there is decreased brain perfusion. There is decreased cerebral or brain perfusion. This is one of the mechanism. but more common than that, okay, more common than that because of electrolyte imbalance. So which electrolyte usually is associated with seizure?
Sir, potassium and sodium, sir, they can carry electric impulse.
Potassium,
When they are out of balance, so there will be that abnormal electric impulse, sir.
Okay, now listen here. Regarding the electrolyte, the important electrolyte which is associated with seizure is the sodium. Sodium, okay, rather than potassium, it is sodium. Potassium imbalance doesn't usually give rise to seizure. It will be associated with so many other problems like arrhythmias and things like that. We'll talk about it later, but sodium is the one. Both in case of hyponatremia or hypernatremia, the child will be having seizure. Hyponatremia or hypernatremia, in both conditions the seizure may be there. The next topic for us is electrolyte imbalance, and during that discussion we'll talk about this extensively. Acute renal failure is a very known complication of severe dehydration, and this type of renal failure is called pre-renal failure. Pre-renal failure, because of loss of fluid from the body, the person suffers from hypovolemia and there is decreased kidney perfusion. This is called pre-renal failure. If we can diagnose this in time, it can be very safely treated by giving IV fluid. But if the diagnosis is late, pre-renal failure will be converted into intrinsic renal failure, and then we need to restrict the fluid for the management. This is such an important point. In the beginning, pre-renal failure, let's treat it just like a case of severe dehydration. Patient will recover. If there is delay in the management, this pre-renal failure will develop into intrinsic renal failure by causing acute tubular necrosis. Then fluid should be restricted, and the treatment is very difficult after that. Coma is always a complication of very severe type of dehydration only. Now at the end, okay, I have prepared some of the class work for you. One of them we are going to do right now, so it will make the concept very clear for the students, okay, if somebody is still confused regarding this, okay. And the second one probably I'll give you as the assignment later on. Now let us solve this problem number 1 right now. Now see here, what is the problem? A 5-year-old boy with a weight of 18 kg presented to the hospital with diarrhea and vomiting history. On examination, he had 15% dehydration. So this is a severe dehydration, isn't it? 15%. Calculate the deficit fluid and maintenance fluid, and how will you give this fluid to that child during the management. So all of you, please solve this, okay. I'll give you a bit of time, and don't worry, we will not waste time. I'll explain it together, okay. Now please proceed further. So what are the important points you need to note here? Note the weight of the child. Age is not important here, okay. Weight is important. So weight of the child is 18 kg. And what is the percentage of dehydration? 15%. So this, from these 2 points, you have to calculate the deficit fluid, you have to calculate the maintenance fluid, and how will you give to that child for the management. Now the weight is 18 kg. So what is the deficit fluid for 18 kg child?
1400.
270.
Sorry, let's talk about the maintenance fluid first. Okay, good. Maintenance fluid is
1400.
1400
ml,
ml.
sir.
1400 ml.
1400.
Okay, I want to ask every student, okay, I don't know whether they are listening here, because some of the students, they just open their Zoom and they disappear somewhere. Please, the class is not for those type of students, okay. If I am explaining like this, you have to listen here. That is the important point. So 18 kg, the maintenance fluid is 1400 ml. And how we have get that value? For first 10 kg is 1000 ml, and another 50 multiplied by 8 would be 400. So total is 1400 ml. So this is the maintenance fluid in 24 hours. Now let's calculate what is the deficit fluid.
180.
Okay, what is the deficit fluid? Now the weight is 18 kg, isn't it? Weight is 18 kg. So what is the amount of dehydration in this child? What is the dehydration? What is the percentage?
15%. 15%.
15%.
150.
15.
150.
Very good. 15% means 150. That's what students often get confused. They just multiply by 15, and that will be the wrong calculation. 15% means 150 ml, not only 15. So what is the calculation now? Yes,
2700.
2700 ml, right? Yes. So this is the deficit
Yes,
fluid.
sir.
Just add this together now. Just add this together, then total fluid will be there. Okay,
4100.
4100.
4100. Very good, 4100. Excellent. Now this is a case of severe dehydration. So you want to give bolus. You want to give bolus to this child. So it's up to you whether how many boluses you can give. Okay, so very safe type of answer. You can give 2 boluses, you can give 3 boluses, but how much boluses you give, you have to adjust it later on. So let's say we are giving 2 boluses. So this 2 boluses is equivalent to, so 1 bolus is equivalent to how much? 18 kg multiplied by 20, because 20 ml per kg. This is 1 bolus, and I can multiply here again by 2 because I am giving 2 boluses. So how much will be this?
720.
720.
720.
Excellent. 720 ml is the total boluses which I have given to that child. Now, okay, so this you just keep it here. Okay, forget about the bolus now. Now another important type of things for us is, this is the total fluid in 24 hours. Let's divide this into two part. First 8 hour and remaining 16 hour. Exactly half amount. So in the first 8 hours, I will do 2050, if I'm not wrong, right? This is the half, and remaining 16 hours, another half. That is 2050 ml. Now, from the first 8 hour, I've already given the boluses. That is 720 ml. So I have to decrease that. I have to subtract that now. So what will be the amount? Just quickly subtract it. 720 from 2050.
1330.
1330.
1330.
30.
Yes. Okay. 1330 ml. So that much amount you give in the remaining 8 hour, and 2050 ml is given in the rest 16 hour, so that the total 24 hour the child should be in the hospital. And this is excellent type of management. There will be no side effect or adverse effect of excessive fluid if you follow this. Okay, this is very commonly done everywhere. But let me repeat again, if you have enough bed in your hospital, if you have enough facility, then you can go for this type of management. If you do not have, you can follow WHO management of dehydration. Now let me deal with that WHO management also here, so that student can easily remember that. See there. So according to the WHO management, this is a case of severe dehydration, so I don't need to remember anything else. We just give 100 ml per kg. Okay, 100 ml per kg of the fluid. Here the weight is 18 kg, so the total amount I will give is 1800 ml of the fluid. Okay, according to WHO, 1800 ml of the fluid. Now this child is more than 1 year old, so in half an hour, okay, I'll give 30 ml per kg of the fluid, and remaining 2.5 hours, I will give 70 ml per kg of the fluid. Okay, so this 1800 ml is the total one. Now in first half an hour, how much fluid the child needs? 30 ml per kg. What is the weight here? 18 kg. So this much fluid the child is getting, okay, in first half an hour. So this is 540 ml, if I'm not wrong, and then rest 2 and, okay, 2.5 hour. Let's write like that, 2.5 hour. The child will get 70 ml per kg. 70 ml per kg. What is the total amount here? Can you quickly multiply 70 by 18? How much?
1260.
1260 ml. See this. This is WHO. This is far much easier than the conventional type of treatment which we provide in the hospital. Far easier, and less amount of fluid is enough here, because WHO doesn't talked about that. In case of severe dehydration, 100 ml per kg of fluid would be enough. So this is how, okay, we deal with this type of dehydration.